Well, we're close enough. I'm going to go ahead and get us started, Dr. Ross, if you're ready.
Yeah, please go ahead.
Great. I think there'll be a lot of discussion for this. So this is John Green. I just want to welcome everybody to this month's MTAC conference. It's a real pleasure to introduce our speaker today. For those of you who don't know him, Dr. Sam Ross, affectionately known as Sammy Ross of the Sammy Ross Trauma Center. I didn't mean to steal your thunder if you were about to do that, but we've had the pleasure of knowing Dr. Ross since he was a little bitty medical student, and now he's made his way up through the ranks to where he's a nationally recognized researcher in public health, and he's been identified by the American College of Surgeons as one of the future trauma leaders of America, really a star on the rise. So we're hoping to maybe cut you off so you don't have to go anywhere else. But it's just a real pleasure to have Dr. Ross on our faculty and as a friend and colleague. And he's going to speak to us today about ballistics. And you may lose us with your statistics. Some of you may know that this guy's a math wizard. So look forward to your comments. And we want to leave plenty of time for questions. And thank you for being with us and speaking today.
Thanks for those kind words, John. I really appreciate it. I shouldn't lose you with the statistics. I'm not going into crazy things, just kind of overall gun statistics, firearm statistics. But the meat of this talk is really going to be on ballistics. I have some cool videos that Brett Sora was nice enough to share with me. If any of you guys have ever seen his chief grand rounds, he had some really nice ballistics videos that I'm going to incorporate into this. First of all, just like Dr. Green said, I am Sammy Ross from the Sammy Ross Trauma Center, and I'm actually not the third, even though the kind of byline for this was that I'm Sammy Ross the third. There was a Sammy Ross that gave a lot of money to the hospital, or his widow did actually, and I didn't realize it till I got here. And as a medical student, they were like, "Hey, your name's on the wall," and I was like, "What are you talking about? You're pulling my leg?" I thought I was being punked or something, but it actually is somebody that I'm related to. And it's like a third cousin, but unfortunately I didn't get any of the money. So just a couple disclosures on this talk. There we go. So I want to be kind of agnostic to guns. And this is not a debate of, whether you should have firearm kind of legislature, if you should have firearm bans, that kind of thing. I grew up owning guns, shotguns as a kid. I don't have any guns currently, just because I have small kids in the house and that kind of thing. And so definitely kind of in the middle as far as, politically, as far as what guns are. That's not the goal of this talk. This is really to understand the physics of ballistics and firearms in general. So, and then also about how that affects tissue and what we do to take care of that. So there are a lot of kind of violent and graphic images, which should be no shocker to anybody who's watching this talk. Again, thanks to Dr. Brett Sora for those videos. Dr. Ron Singh, a lot of the images here are from him as well. And then Dr. Britt Christmas for some of these statistics. So as everybody's probably aware, yesterday we had active shooter on the UNC campus. I'm a UNC grad. I'm a Tar Heel. Spent about a decade of my life there, undergrad, med school, and public health. And so this hits close to home. This is kind of the environment we live in, where anytime you could have a active shooter, lockdowns, could have mass casualties. And so just like I said earlier, even, no matter what kind of spectrum or where you are on the spectrum as far as gun control and those type of things, this is the world we live in, and you have to understand firearms and the damage that they can do to tissue. And so the overall outline for this, we're going to talk about statistics first, and then go into some definitions. We'll talk about internal and external ballistics, terminal ballistics, as far as the damage to the tissue, morphology of gunshot wounds and shotgun wounds, and then some caveats for the actual medical examiner and kind of CSI type issues. So epidemiology. So there's over 100,000 gunshot wounds annually in the United States. There's they break it down into intentional and unintentional for the CDC. And we'll go into some of those numbers. There's been many high-profile cases with outcomes that have been affected by a medical examination, as well as the CSI. You think about things like JFK and the magic bullet, O.J. Simpson, and other kind of CSI things on TV. But clinical experience really does not equal forensic experience. So trauma surgeons and emergency physicians and even neurosurgeons are pretty bad at predicting, what exactly occurred and what kind of gun or caliber was used for these kind of wounds. And so we'll go over what these look like and kind of the physics behind how ballistics damage tissue. Over the past decade, there's been about a 25% increase in annual firearm-related injuries. The CDC in 2020 says that about 53% of all suicides and 79% of all homicides were firearm-related, and approximately there's been 4 times as many injuries as deaths. So, if we have 40,000 deaths from gunshot wounds, so there's about 5 times that number of injuries. This accounts for over 70,000 emergency room visits. And over the past decade, there's been a steady rise in gun violence throughout the country, as well as in our area. So I'll go through first our experience with gunshot wounds since 2012. So this is actually just our first quarter data for our trauma center. This is the adult patients. And you see that overall, our penetrating rates are about 17% in the adult patients, only 3% in the geriatric population. That includes gunshot wounds and stabs, but as I'll show you, the gunshot wounds are much higher. And then our overall number of injuries for violence-related injuries, you see our assaults, blunt assaults there in the blue line, so 300 to 400 a year, and it's been pretty steady. However, our gunshot wounds and the red lines have gone up over time, really since about 2015. We've had a 20 to 30% increase per year. And then in 2020, it shot up in that kind of summer of violence that we had. 2021 went down a little bit, and I hadn't included 2022 in here, but that also went back up to the 2020 level. So just in Q1 of 2023, we've had 102 gunshot wounds come to our trauma center. Our highest injury rate is for blunt injury for MVCs at 400 in just the first quarter. When we're looking at our deaths from gunshot wounds, again, about a 20 to 30% increase since about 2015 per year. So we're up over 60 gunshot wound related deaths in adults. This also has kind of translated into increased gunshot wound rates for pediatric patients, especially our teenage patients. And so our penetrating rate used to be down below 10%. So right now it's at 14%. This is for the whole year of 2022 at 14%. So about a 50% increase in the penetrating rate from classical. And then again, since 2015, we've had a 20 to 30% increase per year in the number of gunshot wound injuries. We're up above 100 in 2021. And then last year alone, there was 112 gunshot wound injuries for pediatric patients. We're looking at the number of deaths from gunshot wounds. Again, it's been increasing since 2015, about 20 to 30% per year. But you see this big jump from 2019 to 2020, and then 2021, we had 16 deaths just for kids for gunshot wounds in 2021. So when we look at the whole country, we see that the number of traumatic deaths, and this is from 2012 to 2020, has increased over time, as you'd kind of expect as our population has grown. So it went from 190,000 people per year to 270,000 people per year dying from a traumatic cause. And it's the number one cause of death from basically infants to 45 years of age. And that's kind of how the CDC breaks those age categories down. So the number one cause of death is trauma for that age group. Then we're looking at the classic causes of death. The number one classic cause of death has been motor vehicle crashes. And up until 2020, that was about 40,000, went from 34,000 to 40,000 patients or people per year. However, what we see is that over time, gunshot wounds have actually caught up to motor vehicle crashes. So it's gone from 33,000 people per year died from gunshot wounds to over 45,000 people now. So it has leapfrogged motor vehicle crashes as the number one cause of death, preventable death as well in the United States. So 45,000 people in 2020 died just from gunshot wounds. When you break that down into homicides versus suicides, it's about almost 20,000 homicides per year in 2020 to 24,000 suicides in 2020 with firearms. If you look at kind of over the decades, what this looks like is the rate of gunshot wounds went down in the early 90s with kind of crime fighting initiatives and things like that. But it's starting to have a uptick again in the 20 teens. And then the rates of death for gunshot wounds also have been increasing steadily since the early 2000s. So that's a lot of statistics. I won't bore you to death anymore with a lot of the statistics. I know Dr. Green can't understand them anyway, so just a little jab at you, John, since he's post-call. But now I really want to get into the ballistics of this. So what we really want to understand when we're looking at firearms and how they work and how the bullets of them work are to understand the types of firearms that are out there, the mechanics, the types of ballistics, the physics of the gunshot wounds, both when they're being fired as well as when they're hitting tissue, the force distribution, and then the tissue effects. And different kind of different tissues have different plasticities, and so we'll have different effects on them. How does this impact our clinical management as well, and how does it impact the forensics for the medical examiner as well as the crime scene investigators? So just ballistics, just taken straight from Wikipedia, the holy grail of truth in our society, is the field of mechanics that deal with launching, flight, behavior, effects of projectiles. And most of we talked about bullets, but also, bombs, rockets, a slingshot is still a ballistic, bows and arrows, crossbows, and things like that. So a lot of times we have a propensity to say this is a ballistic wound. What we're really talking about most of the time in our line of work is gunshot wounds. So it's fine to use just the term gunshot wound instead of using ballistic wound. So a little bit of definitions first to make sure we're all on the same page. So internal ballistics are what happens to the bullet within the gun. Okay, and so there's a lot of different factors that I'll go into with that. External ballistics, what happens during the flight as it leaves the gun before it hits something. And then terminal ballistics, what happened when a bullet strikes the target, whether that's a person or you're just shooting a stationary object. And so there's a lot of different factors that go into that, but they really boil down to target factors as well as the bullet itself. And we'll go into a lot of detail on differences in bullets. Other definitions, muzzle energy, and this is the kinetic energy of the bullet as it leaves the barrel. We usually talk about this in foot-pounds. And then terminal energy, the kinetic energy of a bullet as it strikes its target. And we'll talk about kind of the equation for that. And one of the key things is it's not necessarily the size of a bullet that matters most, but the energy can really be more so from the velocity. We'll go into the equation for that. And so there's a lot of different types of firearms that we see injuries from all the time. Handguns, rifles, and shotguns, and we'll kind of go into differences and these and how they work, and then the ballistics associated with them. And then I'll have some very cool videos to show you. So pistols and revolvers. So everybody probably knows the difference here. Revolvers we think of as, like Dirty Harry with his Magnum Special. It's a wide variety of calibers. So you can have something as small as like a little pocketbook handgun, 22 caliber, up to Smith & Wesson Magnum. These are usually like something like 38 Special or 357 Magnum type of cartridges. They can be single action or double action. You can think about single action as like your cowboy revolvers, where you have to cock it back first before you can pull the trigger for the firing pin to actually engage the cartridge. And double action, where you pull the trigger and it will pull the hammer back and then fire in the same motion. Handguns can also be pistols. So the most common type of modern handguns, either semi-automatic ammunition is magazine fed. And you can think about this as like 9mm, like Glocks, and it's probably the most common one that people think of. There's lots of other ones like 45. These are semi-automatic. So every time you pull the trigger, you're going to have a bullet that's fired. So this is a good video just to kind of understand how this works mechanically. This is from YouTube. It's got some cheesy music here, but so there's, as you insert the magazine, inside the magazine, there's cartridges in a line. There's a spring underneath, and then there's this follower within the magazine that pushes off the floor plate. And so as you pull back the slide, you'll engage the first cartridge, and when you pull the trigger, the firing pin will fire the bullet, and then expel the casing from the last bullet, and in that same motion, load the next cartridge in. Then this happens again and again and again as when you're pulling the trigger. So that gives you a good idea of how a magazine works in a handgun. And it's the similar principle in like a AR-15 or something else. There you go. In general, rifles, these can be bolt action, which require manual manipulation of the bolts. And these are most common in like hunting and competition shooting, or like a sniper rifle or something like that. I see Dr. Clemens in the audience there too. It's probably more familiar with that kind of a thing. They can be semi-automatic as well, which fires one round for each pull, very similar to how that video showed. These are magazine fed as well. This is a good example of this, like M16 or AR-15 as they're known now. Machine guns can be fully automatic. So these continue to fire for the duration that the trigger is pressed. In general, we don't see wounds with this, and one of the main reasons is ever since 1936, these have been greatly limited and outlawed. And the reason for that is, as you can imagine, in 1936, you had a lot of people running around with Tommy guns shooting people, and so they were trying to get a control of automatic weapons at that time. So we don't really see as much of those. And so although we think of like things like in terms of assault rifles and being automatic, most of the assault rifles that people have in civilian use are semi-automatic. Shotguns, most everybody's probably familiar with these. These can be single barrel, they can be double barrel like this with a over-under. Or it can be side to side. You think about like Yosemite Sam or Elmer Fudd or somebody like that. They can be pump action, or they can be semi-automatic as well, kind of like this military shotgun here. And the key thing for difference in this, and we'll go through this, is the spread from the projectiles is immediate, and so that you're not going to get just one area that you're going to have tissue effect. So what a cartridge actually is, and when we think about a bullet, it's actually multiple different pieces. And so before something is fired, this is how it all fits together. And so there's a primer here that is hit by the firing pin. This ignites the powder, so the gunpowder that's within the casing. This is the casing. This part is what's ejected in the handgun. The slide that I showed earlier in that video. And then the projectile, or the bullet, is actually either made of lead, brass, or other metals. And I'll show you differences in there as well. And so we think about caliber. So this is the measure of the diameter of the projectile. So how wide this is. It's usually either in millimeters or fractions of an inch. So like a 9mm bullet versus like a 45, which is almost half of an inch. The length is typically measured in millimeters. And that's from here to here. And so different firearms are going to have different bullets that they can use, and they'll change as well about the kind of length that the projectile can fit in there. Why that's important is because the longer the projectile, the more gunpowder that you can have within the casing, and that means more force, more velocity. The weight is also important, and so this is usually measured in grains. And so something might be, similarly wide, but have a longer projectile, or it could be heavier with different type of materials, and therefore the heavier it is, also the more force you're going to get out of it. And so these are two different casings, or sorry, two different cartridges, but they have the same caliber, but you see the length here is different. So the actual force that they're going to have delivered to tissue or a target is going to be different. And in general, this one's going to have more because of more powder that's within it. And so here's an example of the different types of bullets that we see. So we have something like a 22, which is, like I said, that like pocketbook handgun. This is 9mm, which what we typically think of for something like a Glock 45 handgun. And then you can go up to 5.56, which is typical NATO rounds and assault rifles. 7.62 is also, this is one that would be like an AK-47, and then a 30-06, which would be like a hunting rifle. So these ammunition types also differ by the kind of makeup of the bullet itself. And so, like I said, they could be different materials. So it could just be lead, or it could be a full metal jacket. So that would be, so this cap is just lead, or this projectile is just lead here, whereas these have a full metal jacket around the lead. Those can be different materials, could be steel, jacketed hollow point, which are like these, and these are designed actually to expand out as the projectile goes through tissue, and I'll show you kind of examples of that as it spreads out. And so it causes a bigger surface area, and also has pieces that break off and cause fragmentation. There's a soft point here as well, which I'll show you that, which is designed to kind of implode on itself and also cause a larger area as it goes through tissues. And then we have the differences in birdshot, buckshot, and slugs for birdshot, buckshot, and a slug for the shotgun rounds. So again, internal ballistics, we're talking about the bullet, the gun barrel, and propellant. And what happens, and I'll show you a video here in a second that demonstrates this, is the firing pin is away from the primer, and then when you pull the trigger, the firing pin, the hammer hits it and hits the primer. This primer piece then ignites the powder that's within the casing. That expands. That expansion causes the casing to separate from the projectile. Projectile is sent down the barrel, and it's usually in modern firearms, these are more sort of grooved barrels than smooth barrels, and I'll show you a difference in those too. And then the projectile leaves the gun barrel. So this is a demonstration in 3D, if it'll work. Here it goes. I'll skip to the part that's important for this. So this is the firing pin. Just to give you a better view of that. So the hammer hits the firing pin. All right, that gives you a good idea of exactly how that works. Also important there, they showed that the casing is actually injected because of the force down the barrel, and so that same force backwards makes the slide come back. And just how you can on a handgun slide manually back with your hand, that's how the force you get on the slide is from the projectile itself being fired. This is the difference between a rifled barrel, so grooves, and then a smooth bore barrel, which we really don't use as much anymore. And the reason for that is because these grooves give you a spiral as the projectile leaves the barrel, which is more aerodynamic and more likely to continue in a straight line. This is important, as we'll go through in the kind of CSI part of this, is those make specific grooves. Another piece of this is gunshot residue. So just when that primer ignites the the gunpowder, parts of that also go on the hand of the person who's shooting. And actually, in all the traumas when I was a resident, we used to put bags on people's hands so that they could get the CSI could do gunshot residue later on to see if they fired the firearm for whatever, either if they were a victim or if it was a suicide attempt. And so there's specific kind of electrochemistry that they can run to verify that they have gunshot residue or not. These are those tool markings that I mentioned as far as the barrel. So there's certain striations that are on the projectile itself. And that kind of comes from these grooves and lands as the barrel is rifled. And so there's specific ones for each firearm. Different types of firearms have different ones, but they're pretty unique where they can actually differentiate whether they came from that exact gun or not. And that's by the width, the depth, the direction. So it could be clockwise or counterclockwise, the type of projectile, and then also the type of powder that was used. And so we really don't want to instrument these bullets when we remove them from patients. So if you're doing like a bulletectomy, or you find a bullet like hanging out in the peritoneum, what you don't want to do is grab it with something metal. And so usually you'll put something like these piece of red rubber on a forcep, or you can use like shods for rubber shods. And so pull it out like that. The other thing that we see from movies all the time are like getting that classic thunk in the metal tray. So you don't want to do that either. So you pull it out and you thunk it into the metal tray. It sounds cool, but what you want to do is put it into something plastic so that you're not having marks on there as well from the metal. So the casing can also have markings on it. So when the hammer, the ignition pin hits the primer, it can make different markings. And so the casings are also important. So recovering the casings is important for CSI. And so that firing pin will hit in kind of different ways on the casing. Similarly, the extractor, as those casings are ejected from the firing chamber, those can also make specific marks and kind of bring it back to that specific gun. Something important for kind of the legal aspect of this is that something called the chain of custody. So when you extract a bullet from a patient, we have to actually send that to evidence, and it has to have kind of a chain of evidence from you to law enforcement or whoever else handles it in the interim. And so this is what we do. This is our form here at CMC, which also means that you could be called to testify about removing that instrument. So whenever I do it with residents, I always make the resident take it out, so I don't have to go to court, and they can go to court instead. All right, so getting to external ballistics. So this is as the bullet actually leaves the barrel and is going through the air. So this behavior, has a lot of different factors that can impact its trajectory. It can be gravity, air drag and resistance, the wind, the actual spin of the projectile, the wadding material behind it. And as you get to shooting things like sniper rifles, like miles, you're talking also like the curve of the earth and the turn of the earth as well, and like things like Bernoulli's effect. So I'm not going to go into that. Dr. Clemens might have experience with that or something. As you're going from internal to external ballistics, this is just a good representation of kind of that wave that you see of the bullet as it exits the barrel. But more important to us is terminal ballistics. So it's actually the behavior of projectiles that strikes and departs energy into its target. So wound ballistics is a subdivision of this terminal ballistics. And the factors that affect the wounding are energy. So we'll talk about that equation here in a second. Bullet properties, like the different types of bullets that I mentioned earlier, as far as like hollow point versus soft point, the tissue encountered. And so this is why we get to this really important equation. So the kinetic energy is 1/2 the mass with the velocity squared. And that's why it's really more the velocity, so the amount of gunpowder that's in the casing, that is more important than the size of the projectile itself. And also the kinetic energy we talk about again is in muzzle energy in foot-pounds. There it goes. All right, so the other definitions to think about for terminal velocity or terminal ballistics are the permanent cavity and the temporary cavity. So the permanent cavity is the actual path that the projectile goes through the tissue. And so you see here as the bullet comes into the tissue, it makes a straight line. It starts having wobble or yaw, as I'll see in a second, and then can come through. We've all seen this as we've treated gunshot wounds. It can make kind of a spinning effect and cause a bigger area than it is width-wise. This temporary cavity, and you'll be able to see in these ballistic videos that I'll show you, is the expansion of the tissue around it, and there can be damage there. This is kind of what we think of as the blast effect, although that term is kind of a misnomer. The temporary cavity does not necessarily equal tissue damage. And like I said, that's a little bit of a misnomer. As you look through other examples of this, so this is the one we saw before where the bullet just spins and that permanent cavity is kind of smaller. This is that was a 7.62 NATO round that this was from a textbook. This is an AK-47 7.62 round as well. As it spins, when it has more of a linear trajectory, the temporary cavity is smaller, but as it spins wider, the temporary cavity is wider. Now, this is a 5.56 NATO round that has fragmented, and you can see that with that fragmentation, the permanent cavity, so the permanent damage area, is much wider than these previous ones because the amount of force is distributed over that wider area with fragmentation. Another thing is you might have pieces of bullets that go in different directions. And we have seen that as well, where you have multiple different pieces, different places, and it doesn't necessarily mean that there's kind of an entrance and an exit, and then there's a straight line in between the two. So you have to keep that in mind as you're exploring patients to make sure that you're finding all the injuries, and it's not necessarily just a straight line. All right, so what is the bullet caliber at AR-15? This is kind of a audience participation. You might know. Non-military people? I know you guys know. Dr. Miles is out of there. Anybody in the classroom now? No? All right.
There was a chat comment of 5.56.
Oh, okay. Who said that?
Stephen
Let's see.
Graham.
All right. Yeah, that's right. So, and the reason I mentioned that is because that's actually the 5.56 round here. I'll show you. That's this round right here. That's smaller in width than a 45. Than a 45 and a 9mm, and it's more in between like this 10mm and a 22. And so if we think about the caliber, it's not the width of this. It's not the mass of this projectile. Again, it's the amount of gunpowder that's in here that can lead to higher velocities and more force projected. And again, just to give you another example of the types of bullets here. So again, this is a 5.56, so much narrower than something like a 45 or a 9mm, but you're going to get a lot more force when it hits the tissue with something like a 5.56 or a 30-06 or a 7.62. All right, so again, the bullets can be a full metal jacket where you have the lead enclosed hollow point. I'll show you an example here of what's called a wad cutter and a frangible as well. So this is what they look like when they hit tissue or hit a target. So these hollow points will kind of flower out like this. You can imagine that's a lot more um, surface area to impact. So that permanent cavity is going to be larger. These soft points, they kind of mushroom out and have a similar effect. And then these are just smaller hollow points as well. Frangible bullets, what they're designed to do is to fragment. And so what happens, say you want to hit a target, but don't want the bullet to go through and through somebody. You want it to just hit the target and then stop. Also, if you're like at home and you want to, this is for self-defense, so you don't want to risk like hitting somebody and then hitting your kids or hitting your dog or something. These are designed to fragment when they hit soft tissue. And so they have low mass but high velocity. And again, this is what those will look like, those fragmented areas, and possibly different trajectories for those fragments. So the tissues themselves also have difference in pliability and elasticity. So things like skin, muscle, lung, and bowel are much more pliable than less elastic tissues like liver and kidneys. And so you'll have different tissue effects, especially from the temporary cavity on those tissues that are less elastic. So this is an example of, or this is kind of leading into the ballistics videos, and I guess how the ballistics gels were created is this colonel was Martin Fackler was in the Army Medical Corps in Vietnam and saw the damage that ballistics firearms were doing, and wanted a way to try to recreate that and learn from it. And so with the help of the FBI, they created this ballistics gel, which is 10% gel, which kind of mimics soft tissue and muscle. And so with this, we're able to actually see the kind of effects of different firearms and ballistics on tissue itself. And it gives you a good idea of the amount of force that's transferred into patients or that if you're in military, the enemy. So we'll go through different examples of ballistics for this. So for a pistol gunshot wound, and these are, again, thanks to Dr. Sora he actually made these ballistics gels and filmed these with a slow motion camera. So this is an example of a pistol going through ballistics gel. This is a 22, so that smallest bullet that I showed you before. And this is at standard velocity and I believe this was a hollow point, and this was at about 1,000 feet per second is the velocity of this. And you can see there the temporary cavity that's created. And this is that a slide of just that temporary cavity. And so this block is about 18 inches long and about 8 inches wide. And so it gives you a good example of even though that's a tiny bullet going through, you get this huge temporary cavity through the ballistics gel. This is the next one up. It's a 9mm Luger. So you think about this as like one of those Lugers from the Nazi movies, like Indiana Jones or something, shooting a Luger through somebody. And this is, again, at about 1,000 feet per second. Takes a second. So much more force in that one. You can see the temporary cavity there on that frozen slide. So that much bigger temporary cavity here. So this is almost like almost 6 inches across. Next one up is a 45. So this is also another handgun. This is again about 1,100 feet per second and a little bit heavier bullet. It's 185 grains. So a lot more force in that one. You can see the size of that temporary cavity. It's actually wider than the thing is at baseline, so it's about 8 inches across there. And so you think about if you got shot in your liver with a 45 like that, that's the temporary cavity that's going to be created in your liver. And things like liver and kidney are not as forgiving and won't expand and contract again. And so you're likely going to have tissue damage in something like that. If it's just soft tissue, you're not necessarily going to have permanent damage in that temporary cavity. Again, this is what those rounds look like once they were extracted. This is an excerpt from one of the medical examiner handbooks about pistols just in general and pistol rounds. And it's due to the elastic nature of most human tissue and low velocity of handgun projectiles. It has been long established by medical professionals that gunshot wounds, that the damage along a wound path visible at autopsy or during surgery cannot be distinguished between the common handgun calibers used in law enforcement. That is to say, operating room surgeon or ME cannot distinguish the difference between, say, like a 3.5 or a 45 caliber projectiles. And so sometimes we'll get this question in the operating room, like what kind of round do you think it was? And we're pretty poor at actually determining, if this was a 9mm, if it was a 45, if it was a 22. So you might guess, but you really don't know just looking at this from a pistol round itself. And like I showed you earlier, the weights are pretty similar, even from a 22 to 45. And then also the velocities are pretty similar as well. So when you actually have a pistol round wound, that might be what you see on the outside. But on the inside, laparotomy, you might have a lot more tissue damage as that ballistic, if that round starts spinning. And so you might get something like this where you have complete kind of transection and then spatulation of the small bowel there. Or you might get something that's like a pinhole if it goes through kind of just in a linear direction like that. The other thing to think about are secondary missiles, and that's both from fragmentation of the ballistic round, as well as things like bone, like here where you can have the round hit bone, actually miss a vital structure, but then shards of bone actually go and injure something like the femoral vein or artery. This is what we kind of the lay people probably think when you see a bullet on an X-ray. You think it's going to look like this, but this is only if it's full metal jacket and lodged in there. It's pretty unusual that we see that. Most of the time, what we usually see is something like the jacket and the bullet have separated. And so this might be the lead, this might be the full metal jacket, this would be shards of that in between. And then you have kind of injury from here all the way to there. You see all these tiny little projectiles can injure things as well. So in this area, might injure ureter, femoral artery, vein. Any one of those tiny little pieces could injure all those. And then this is also an example of, this is actually just a through and through injury. And you don't necessarily know whether it's an entrance or an exit wound. And so I'll talk more later too about, it's important just to call them wounds and not speculate what's the entrance and what's the exit wound. All right, so rifle gunshot wounds. These can be pretty devastating, a lot more force. And the reason for that, again, is because higher velocity. And so these are two ballistics gels for a 5.56 NATO round and then a 7.62 Winchester round. So again, these are going to be like these two rounds here. This is actually a 50 cal. That's something that would be used like a 50 cal sniper rifle or 50 cal machine gun. Not something you're going to see usually in civilian use. All right, so here's the 5.56. This is going to be about 2,800 feet per second. And again, this is actually, it's a lighter weight, 75 grains compared to like that 45 handgun round. But see the difference in the force that's created here. So that temporary cavity was just huge. If you look at this, it's almost double the size or the width of that ballistics gel. And again, this is almost 3 times the speed, so 3 times the velocity of the handgun at 28 versus like 1,000 feet per second. And that's what it looks like. This round actually fragmented and had spinning. And so just like that textbook example, you had fragmentations going in different directions, you know, it came out 3 different places. And then you had this big temporary cavity, or actually this would be the permanent cavity as it's spun. And then temporary cavity would be that large wide area that you see on that last slide. This is a 7.62 round. So this round has more gunpowder and then also weighs more. And this is about 7,200 feet per second. You saw that round actually, it dented the table end, just the force of the temporary cavity. And so you can imagine that hitting a patient and then what their liver would look like if that temporary cavity is where their liver was. So that's like about 3 times the actual original width of this. And then again, when Dr. Sora looked at this, the temporary cavity or the permanent cavity was pretty large, and then you had multiple areas where fragmentation occurred. And that's the size of that bullet just compared to the temporary cavity there. Or, sorry, the permanent cavity. This is from Dr. Sora as well, some examples that he saw, and it might have been before he came in, but he saw plenty of examples like this when he was a flight surgeon. And so you might have a wound like this on the outside, so where you think it's through and through, definitely a large wound here, but then actually on the inside, that temporary cavity created almost like a giant Morell's lesion between the abdominal wall. And then just from the temporary cavity injury, the colon had basically had a perforation just from that blast effect. In the interest of time, I'm going to kind of skip through some of these. Kind of showing this as well. All right, some other examples of rifle gunshot wounds. And then, you know, how do you manage these? So it used to be thought that you would just let these drain on their own, those large wounds like that. But now the more thought is to debride as much non-viable tissue as possible, and then specifically for the rifle wounds, you're going to have that temporary cavity around it, and that's going to delineate over a couple days. And so you're going to want to observe those. I had a patient about 2 years ago that was shot in the leg multiple times with an AK-47, and you know, the initial operation, they didn't actually have any vascular injury. And didn't have too much soft tissue to debride that looked non-viable. But then going back after multiple injuries or multiple takebacks, had further delineation on each takeback of more ischemic tissue, more tissue that had been injured from that temporary cavity from these, you know, high velocity wounds. All right, so shotgun wounds. These are can be very devastating if they get to the hospital. A lot of times, if you're shot with something like buckshot or a slug, you're not going to be able to get to the hospital because of the amount of force that's distributed, as well as the amount of area that's distributed over. Patients that we do see with these are usually from birdshot, as you see in these X-ray examples. And so that distributes a large amount of force, but over a large amount of area. Examples as well of ballistics gel testing on shotgun rounds. But again, this is a 12 gauge shotgun round, just comparison to the rifle rounds earlier, the 5.56 and 7.62 50 cal. And so this is a 8 shot. So this is bird shot basically at 1,200 feet per second. And then again, it changes based on how far away you are, because you're going to have spread immediately from the barrel as it leaves. So this is at 5 yards away. It's a pretty devastating amount of injury from this close up. you can see just how contorted everything is there. So even with birdshot, if you're shooting someone at pretty close range, it's going to have a large amount of tissue damage. This is with, again, birdshot, but this is at 10 yards. And so much farther away. And you can see how it goes more linear through the tissue. There's not as much of that impact damage on the front end. This is buckshot, so much larger projectiles at 1,300 feet per second. Again, pretty devastating amount of force transferred in initially. And then last, this is actually a rifled slug. And so this is one giant projectile at 1,600 feet per second. So this, the reason this, you can't see really what happened there, the table and the whole setup that he had broke when he fired this in because of the amount of force that went into the table. And so everything here, the projectile, the ballistics gel was basically like cut in half. So this gives you an idea of the difference in the kind of spread from shotgun blasts from, this is again birdshot, from different lengths or different distances. So 5 yards, 10 yards, much wider, and then 15 yards, much more scattered. Other thing you might see with shotgun wounds is this kind of pedal mark, and this is from the actual cartridge itself from the shotgun. And so as you see here on this next, this is the way a shotgun shell is kind of created. So you have the different type of shot that's on the inside. The actual gauge, so there's different gauge shotguns, usually something like a 12 gauge. I didn't learn this till recently, but that gauge is how many lead balls you can have a diameter for that make up a pound. And so the lower the number, the wider the barrel. Anyway, so this also has this kind of plastic outer casing, the shot, and then this fiber wad behind it, which you might also pull out of wounds, and then the powder and that basically an anvil or primer there. And the wounds themselves, you'll see pretty large, devastating wounds, and you might find pieces of the casing or the wadding in the wound itself. The other thing you might find is clothes. So because it's such a large area, so if someone gets shot over their jeans or coat or anything, you might be pulling out pieces of clothes. And we've patients who survive go back and a lot of times they'll have wound issues where they have like chronic draining sinuses and things, and it's because of that tissue or sort of the clothing or wadding are actually still within the wound itself. You'll see that casing look like that and creating those kind of rose petal or those petal marks. This is what those x-rays for birdshot will look like. And you just can imagine like this in the peritoneum, you might have just hundreds of tiny little injuries to the bowel. And you can't obviously resect all that. So trying to manage this, it's more trying to conserve the amount of bowel that you have there instead of doing complete resection. Again, here you see like this wound, this large shotgun wound, and this looks like projectile underneath the skin. And again, it was the casing from the gunshot wound. Lastly, going very quickly through just kind of morphology and things for medical examiners. So this is from Dr. Singh and Dr. Sullivan on the kind of the medical examiner piece of this. And really the most important thing you can do is be objective and have good descriptions in your surgery notes. Just say what's there and don't try to kind of elaborate or say what's entrance and exit, what's like what kind of caliber it is. And the reason for that is because if these type of things go to court, the lawyers for the other side can always say like, well, this surgeon report said this was an exit wound, this is an entrance wound, it was this caliber, that doesn't line up with the what the police say. And so just going to be very objective and don't try to make assumptions. Can be very important. Just the kind of the wound morphology itself, gunshot wounds that are very close have that kind of a stellate appearance like this. Ones that are a little more medium range, a couple feet, will have the wound and then some stippling. That's actually from the gunshot or the gunpowder exiting, as you can see like here. And then ones that are farther away will just have the single wound. So this kind of stellate wound like this, most likely right up close. The entrance wounds, again, don't use that terminology, but just for the medical examiner, entrance wounds usually have the marginal or annular abrasions around it. But it can be very hard to tell sometimes whether something like that is entrance wound, if that's an exit or an entrance wound. Even something this small, I've seen, it could be an exit or an entrance wound. So just again, don't describe it as exit or entrance. The things that could affect those, how they appear, are all right there. And again, presence of clothes. You can also see up close wounds that have contact burns as the powder is ignited, leaving the gun barrel like that. Like that. And then tattooing, that's a term for where the gunpowder is, again, coming out the barrel and causing almost like small burns around the wound itself. And we'll belabor those points. One last thing is for forensics, try if there is gunshot holes through clothes, try not to go through those holes themselves, because that can be important evidence for police and CSI. And try to protect those clothes and fold them up. Stuff like blood splatter might be important later. Go through all these. All right. Well, that's everything I have. Really, just the kind of the key takeaways for this is really understanding the physics of ballistics, both inside the gun, outside the gun, as it hits the tissue, and describing the wound morphology, and avoid those kind of subjective terms like entrance, exit, and then the caliber of the weapon. Just describe what you see. That's it. I'd like to thank, again, Dr. Singh, Dr. Sora, Dr. Christmas, Dr. Green for having me, and Scott Wilson for organizing this. Thanks. I'd be happy to take any questions.
Thanks, Dr. Ross. That was great. We'll open it up for questions from the audience.
Dr. Ross, Mike Gibbs, great talk. And the more jokes about Dr. Green, the better. Thank you.
It wasn't a joke, Mike. He's right. I don't understand his statistics.
The more jokes about Dr. Green, the better.
It's kind of hard doing this when you're making jokes and nobody laughs because everyone's muted.
I was laughing to myself, I promise.
Mike, you or your military crew have any additions, things that you think about, things I left out?
Hey, Dr. Ross. No, I really appreciate your review. Thanks for doing that. I did actually want to ask your thoughts after this. So if we don't see nearly as many high velocity wounds here in the civilian sector, do you think you would have a change in practice in the management of a transabdominal high velocity wound as far as leaving them open, consideration for anastomosis? Do you think that right now you would handle that patient differently, surely on the wounding pattern?
Yeah, so like if you had like a colonic injury with a 9mm handgun, the amount of force that's distributed, you're probably not going to get a huge temporary cavity around that. And so just debriding what you see at the time of surgery is probably fine. However, I think since I've been here, we've had like a handful of cases like that AK-47 that I described, where you have that huge temporary cavity. There have been one or two that have had bowel injuries that some were managed like you suggest, like damage control, come back again, take a look. And some have been managed like we usually do with handguns, and that didn't end very well for those patients. There's been a couple that I remember specifically. And the reason for that is because of that amount of increased damage in the tissues around it. So the kind of misnomer of a blast effect is incorrect. It's more like direct transfer of force. but it is real, and it's worse for those high velocity rounds. So for something like even for like a hunting rifle that has a high velocity round, I would probably take that patient back and take a second look before anastomosing, if you're not just going to give them a colostomy the first time.
Yeah, I think the other caveat to that one, I'd be interested to hear your thoughts on, is the vascular injury. So I've encountered a couple of these high velocity, specifically arterial injuries, and I'd be curious would you be more likely to shunt that patient or hold on a definitive anastomosis to wait and see if you needed to bleed more tissue? Or would you be willing to actually go ahead and do a primary repair in that initial operation?
That's a good question. I don't have a good answer for a vascular injury. I think in general, if patients, hemodynamically unstable and have high lactic acidosis or other factors for damage control, then I'm more apt to shunt them than say like our vascular colleagues. They always make fun of us actually for shunting, but that's exactly the patient that damage control and shunting for vascular injuries was created in the military. Those kind of patients with those injuries, especially or like IEDs and having vascular injuries. And so my personal preference, I would probably shunt them and come back and take a look at the tissue later. However, I don't have any good data or experience to guide me from that. Maybe some of my colleagues do. Dr. Thomas, your hand's up. If you're talking, we can't hear you.
Am I now off mute?
Yeah, you're good.
Yeah, I wasn't necessarily going to comment on that specifically. I think with high velocity injuries and rifle rounds, that the progression of the injury, no matter what the tissue is a lot higher. And I think most times a second look is warranted. There's a great, mostly picture book, War Surgery in Afghanistan and Iraq, I think is the title, that I have a copy in my office if anybody wants to borrow it. But the management is definitely different for these kinds of wounds. And I think in the civilian sector, we generally don't see as many of these survivors for two reasons. One is that the weapons used are less common to be high velocity. And the second is the lack of body armor, which is definitely increased survivors. But you get these injuries with body armor that are far away and remote from the site of injury due to that blast effect and wound cavity. I was going to.
You broke up there, Brad.
These injuries can be really challenging, especially when they're up close with a ton of tissue damage. You really need to find the wadding if it's in there and get it out, as that'll lead to fistulization and other issues. Things like diaphragm injury we've seen frequently, where chest wall injury, where you have to really kind of recreate the chest wall or reimplant the diaphragm up higher because you lose so much tissue. And I have a specific example. I can recall a patient that was shot at close range in the right groin, and he had, an common iliac vein injury that was very difficult to control, but then about 150, injuries to the small bowel, to the pancreas, to the, all over the place. And with that smaller bird shot, all those holes don't necessarily need to be addressed, but certainly, leaving them open and oversewing what you can. The arterial injuries, there was most certainly an arterial injury on that one as well, but because of the small caliber and the artery's ability to sort of seal itself off, didn't have to do anything to the artery, but the venous injuries can be really quite challenging. That's the only comment I want to make. Thanks.
Awesome. Thanks for that, Brad. Anybody else have any questions? Well, excellent. Thanks again for the time, and I appreciate everybody listening in.
Thank you, Dr. Ross.
Great talk, Sam, and enjoyed reseeing the slides that Brett created. Thanks.
Thank you, sir.